Okay, so the next topic we are going to discuss is emphysema. So first of all, again, we have to know the definition of emphysema. Then we will go into the detail of its, you can say, types, pathophysiology, diagnosis. So first of all, what is emphysema? Again, it is a form of COPD. It is a form of chronic obstructive pulmonary disease, and this form is going to characterized by permanent enlargement or permanent dilatation of air spaces, and this enlargement is going to be distal to terminal bronchiole. So in the emphysema, the person is going to have permanent enlargement of air spaces distal to terminal bronchioles, and with this the person is also going to have alveolar wall destruction. But please remember, in emphysema the person is not going to have any fibrosis. So this is the definition. The person is going to have basically enlargement of air spaces distal to terminal bronchiole. With this, you can say, enlargement, the person is also going to have destruction of airway wall without fibrosis. And please remember, when the person has a especially loss of alveolar wall, you are going to have loss of elastic recoil. And if you are going to have loss of elastic recoil, it's mean the person is going to have air trapping. So this is the important, you can say, key point in the emphysema. You have to know, if you have loss of alveolar wall, you are going to have loss of elastic recoil. And if you have loss of elastic recoil, you are going to trap the air. So these are the few important points in the definition of chronic, in the emphysema you have to know. Now we have to discuss the diagnostic criteria, like how the emphysema is going to diagnose. Please remember, unlike chronic bronchitis, emphysema is not a clinical diagnosis, because chronic bronchitis, it is a clinical diagnosis. Emphysema, it is not a clinical diagnosis. So it's mean the diagnostic criteria for emphysema is different. So the diagnostic criteria for emphysema include two important things. First of all, it is going to have radiological finding. This is the most common. And then second is the biopsy, but biopsy we don't do. Please remember this point. For the emphysema diagnosis, two important points: radiological finding more common, and biopsy, it is rare but it is definitive diagnosis. And what are the radiological findings? Either it can be on chest x-ray or CT scan. So what are the classic features that are present on a CT or chest x-ray, which are going to be diagnostic for emphysema? So first of all, please remember, in the emphysema the person is going to have barrel shaped chest. So the person is going to have barrel shaped chest. The person is going to have increase interior posterior diameter. The person is going to have flat diaphragm. The person is going to have hyperinflated lungs. Hyperinflated lungs. The person is going to have especially darker lungs because of air trapping. So when the lungs are darker, we call it increased lung lucency. We call it increased lung lucency. Second, sixth point, the person is going to have decreased vascular marking. So these are the six important classic features for emphysema, which can be present on lateral chest X-ray if you want to see these feature. So you will do the lateral chest X-ray. Let me repeat again. The person is going to have barrel-shaped chest. The person is going to have increased interior posterior diameter. The person is going to have flat diaphragm. The person is going to have hyperinflated lungs. Hyperinflated lungs mean air trapped lungs. And if you have air trapping, your lungs are going to be black more, darker more, which is called increased lung lucency. And then you are going to have decreased vascular marking. So these are the few diagnostic points you have to know. And these few points are also mentioned here like for the diagnosis, you can do radiographic study or biopsy. But please remember, radiography, it is most common and biopsy, it is less common. But definitive diagnosis is biopsy. So on the chest X-ray, the person is going to have barrel-shaped chest, anterior posterior diameter, a flat diaphragm, increased lung field lucency. Increased lung field lucency means the person is going to have darker lungs. And then also add, the person is going to have decreased vascular marking. So these are the few radiological findings. Now we have to go into the pathophysiology. Please remember, emphysema, it is a disease of alveoli. It is a disease of alveoli. Chronic bronchitis, it is a disease of airway. It is not a disease of alveoli. Please remember this point. Chronic bronchitis, it is a disease of airway. It is not a disease of alveoli. But emphysema, it is a disease of alveoli. Please remember this point. It is not the disease of airways. And same like we have to know the main problem in emphysema. So four important points you have to know, especially in emphysema. So these four important points are going to be, you can say, main problem points in the emphysema. So the first point is going to be the person has alveolar wall destruction. And when the person has alveolar wall destruction, it means you are going to have loss of elastic fiber. And if the person has loss of elastic fiber, then it is going to cause a decreased recoil. So the person is going to have decreased lung recoil, plus the person is going to have increased compliance. So increase compliance, decrease recoil. And fourth thing, the person is going to have air trapping. The person is going to have air trapping plus impaired gaseous exchange. So these are the four main problems which we are going to discuss in detail in pathophysiology. So the first is alveolar wall destruction. Second, loss of elastic fiber. Third, increase lung compliance, decrease recoil. Why? Because of loss of elastic fiber. Then air trapping. Why again? Because of, you can say, destruction of elastic fiber, your alveoli are not going to recoil. It's mean if the alveoli are not recoiling, you are not, you can say, pushing the air out from the alveoli. Your air will stay trapped in the alveoli. Now we will go into the step by step in the pathophysiology. Again, we have to start first from the irritation. We have to start first from the irritation. Again, the irritation can be because of, so the first step, so these are the steps which are going to be in pathophysiology of emphysema. So the first step is chronic injury. And what is the main source of chronic injury? It can be smoking, it can be genetic cause. Please remember this point. Cigarette smoking or genetic defect are going to cause chronic inflammation, oxidative stress, and protease activation. So all these things are going to cause injury. Second, the person is going to have inflammatory cell activation. And why the inflammatory cell activation is occurring? Because of chronic inflammation, because of oxidative stress. And what are the cells that are going to involved in emphysema? So the person has involvement of CD8 cell, CD8 uh, plus T cell. The person is going to have neutrophil. The person is going to have macrophages. So CD8 T cell, neutrophil, and macrophages. These cells are going to be activated, and when these cells are going to be activated in emphysema, they are going to release proteases, especially elastase enzyme. This is going to damage the alveolar valve. And when your alveolar valve is damaged, it is going to cause loss of elastic fiber. Second, these are going to cause reactive oxygen species release. So these are the few important points you have to know. And then the third step is going to be protease and anti-protease imbalance. This is very, very important in case of emphysema. First of all, we have to understand the normal. Normally in our body, we have one protein or one enzyme which is called alpha antitrypsin. This alpha antitrypsin is going to inhibit the neutrophil elastase enzyme or protease enzyme. So it's mean if alpha 1 antitrypsin inhibit the elastase enzyme, you are not going to destroy the fiber of alveoli. So it is going to protect the elastic fiber of alveoli. But in emphysema, what is going to happen? Your alpha 1 antitrypsin is going to decrease. When your alpha 1 antitrypsin is going to decrease, your elastase activity is going to increase. When your elastase activity is going to increase, what will happen? It will lead to cause excessive loss of alveolar fiber. So the fourth step is going to be alveolar valve destruction. Why alveolar valve destruction? Because of elastase. This elastase is going to damage the, you can say, elastin, and also going to damage the alveolar septa. So these are the few important points you have to know, especially in case of pathophysiology. Okay, so The fourth step we have discussed here, like in the emphysema, the person is going to have alveolar valve destruction. So why alveolar valve destruction? Because of elastase. Elastase is going to break down the elastin and alveolar septa. That will result in loss of alveolar valve. It is going to cause, you can say, alveolar. Uh, it is going to cause dilatation of alveoli. When you are going to have loss of alveolar valve or loss of elastic fiber, it is going to cause dilatation of air spaces. So it is going to form, you can say, large airway spaces. So why and how the airway spaces are going to form in emphysema? Because of alveolar wall destruction. So the person has loss of alveolar wall, the person has loss of elastic fiber, that will lead to formation of large airway spaces. That's why this emphysema is described as air space enlargement, because of this reason. And then the fifth step is going to be like lung mechanics are going to change. What is the meaning of lung mechanics? Like the person is going to have increased lung compliance because because of loss of elastic fiber, you can inflate the lung easily. But the person is going to have decreased elastic recoil. Why? Again, okay, so in this, we are like discussing what are the mechanics changes that are going to be present in emphysema. So the person is going to have increased lung compliance because of loss of elastic fiber. You can inflate the lung easily. When you will inflate the lung easily, it is called increased lung compliance. But you are going to have decreased elastic recoil. So it's mean your lung cannot deflate properly. You can inflate the lungs easily, but you cannot deflate properly. That's why in the emphysema, the person is going to have airway trapping. Why? Because you cannot deflate the lung. You are not going to deflate the lung. It's mean you are trapping the air. And then the sixth step is going to be air trapping or hyperinflation. So the person will exhale poorly. The person has a residual volume increase. The chest remains expanded. That's why the person is going to have barrel shaped chest. So why the barrel shaped chest? It is because of air trapping. And then the seventh step is going to be gas exchange impairment. Why? Again, because of destruction of alveolar capillary membrane, you are going to decrease the surface area for diffusion. That's why in this emphysema, the person is going to have decreased diffusion lung capacity of carbon monoxide. Diffusion capacity for carbon monoxide is going to decrease. Why? Because of destruction of alveolar capillary membrane. You are going to decrease the surface area for diffusion. So this is going to differentiate emphysema from chronic bronchitis. Please remember this point. So these are the pathophysiological steps in the emphysema. Then we have different types of emphysema, and this is again going to be very, very high yield. We have centri-acinar emphysema, and we have second type pan-acinar emphysema. Now we have to know the definition. First of all, what is centri-acinar? This is also called centrilobular emphysema. We have to know the location, we have to know the distribution, we have to know the cause and mechanism. So in the center, centri acinar emphysema, location is going to be respiratory bronchiole. Location is going to be respiratory bronchiole, and it is going to spare the distal alveoli. Please remember this point. In the centri acinar emphysema, your distal alveoli are going to be spared. And what is the distribution? It is going to involve the upper lobes. So the So in the center acinar emphysema, what we are going to discuss, first of all, location. So what is the location? Respiratory bronchioles. Respiratory bronchioles. And second, it is going to spare the distal alveoli. This is about the location. And what is the distribution? In distribution, please remember upper lobes are going to damage. And what is the cause? The cause is going to be especially smoking, cigarette smoking. It is most common. And what is the mechanism? The mechanism is same. Smoking cause inflammation, inflammation cause elastase release, and this elastase is going to affect the upper lobes. So this is the important point you have to know. And then what about the pan-acinar? Same, we have to know the location. This is going to be in respiratory bronchiole, alveolar duct, and alveoli. And what is the distribution? It is going to be in lower lobes. Please remember this point. And it is associated with alpha 1 antitrypsin deficiency. This is the important point you have to know for exam. Like in the centri acinar, upper lobes smoking. In the pan acinar, lower lobe and alpha 1 antitrypsin deficiency. And mechanism is going to same. If you have less antitrypsin, you are going to have unopposed elastase activity, and this is going to cause alveolar destruction. So the person is going to have early onset of emphysema, the person is non-smoker, or the person is having minimal smoking. And also please remember, uh, in this especially, in the type of pan-Hashimoto's emphysema, with the lung, the person is also going to have problem in the liver, because these patients are also having liver cirrhosis. Why? Because of accumulation of alpha 1 antitrypsin in the liver. Again, this is going to be very, very important. So these are the few important points you have to know for your exam. And now you can read these things from here in the book. They have mentioned everything in the mechanism. Next, we have to know the important points about the oxidative stress, like how it is mediated by oxidative stress. So first of all, smoking is going to cause reactive oxygen species production, and these reactive oxygen species are going to cause oxidative stress. This is the important point. And then also please remember, smoking is going to cause oxidation of alpha 1 alpha 1 antitrypsin. So even if the person has alpha 1 antitrypsin, it is going to be functionally inactive. Why? Because of oxidation. So it's mean, if you will do the oxidation of alpha 1 antitrypsin, it will become inactive. So these are the few important points you have to know for your exam. And then what are the clinical feature in the especially emphysema? Again, the clinical features are going to be little bit different from chronic bronchitis. A person is going to have dyspnea, the person is going to have minimal cough, less cough. This cough is not more productive as compared to chronic bronchitis. In emphysema, the person has less sputum production as compared to chronic bronchitis, and in that person is also going to have weight loss. And what are the physical exam finding? The physical exam finding are going to be barrel-shaped chest. A person has prolonged expiration, decreased breath sound, hyporesonant on percussion, and these patients are have pursed lip breathing, and these patients are also called pink puffer. Pink puffer. Please remember this point. These patients are thin, tachypnic. These are the few important findings you have to know. And then let's have a quick review how we can differentiate chronic bronchitis from emphysema. First of all, please remember, emphysema, it is a disease of alveoli. Chronic bronchitis, it is a disease of bronchi. Then the main problem in emphysema, alveolar destruction. Alveolar destruction. The main problem in chronic bronchitis, mucus hypersecretion, your glands hypertrophy. In emphysema, you are going to have decreased diffuse lung capacity. In chronic bronchitis, it is normal. In emphysema, the person is going to have minimal cough. In chronic bronchitis, the person is going to have productive cough. Cyanosis is present in emphysema and chronic bronchitis. In emphysema, it is late. In chronic bronchitis, cyanosis is early. And read index, it is going to be normal in emphysema, but it is going to increase in chronic bronchitis. So these are the few, you can say, differential points between the emphysema and the chronic bronchitis.